This will be presented by Dr. Wairimu Kimani, who is a consultant neonatologist at the Kenyatta National Hospital. Thank you, Wairimu, for agreeing to give us this lecture. We'll have time for a question and answer session. This will be at the end of the lecture. Once we're done with the lecture, and you can type out your questions in the chat box, and they will be answered at the end of the lecture. So I think, Dr. Wairimu, you can go ahead and start the lecture.
All right, thank you, Kenya, for the invitation. So this is really, so this is a really wide topic. What I've tried to do is kind of focus on what local data we have, and also what local guidelines we have to guide our decisions around neonatal sepsis. It's not a new topic. Most of us have looked after. I tried to look in the participant group. I'm seeing a couple of doctors, and I'm sure most of you are clinicians and have encountered a baby with sepsis. So this is not going to be very new in terms of things you have seen before. So first we'll see, let me see if I can advance here. Okay, so this will be our outline. We'll look at some of the epidemiology and try and focus on what we know locally, and then distinguish between early versus late onset sepsis. We'll go through the clinical presentation, which tends to be non-specific, as you know, and then how do we evaluate these babies who we are suspecting to have sepsis, and then what we have as local antimicrobial susceptibility patterns, and then we'll summarize and invite questions and discussion. Okay, so this slide is actually from UNICEF and the Healthy Newborn Network, and just gives us an idea of what are the leading causes of neonatal death. We know neonatal mortality sits at about 22 per 1,000 per year. And more recently, I think has come down to 21 per 1,000 in 2018. And majority of those neonatal deaths are contributed by these top 3 causes. So leading the pack is preterm birth complications, followed by intrapartum related events, of which mainly we talk about perinatal asphyxia, and then neonatal sepsis, which is really the focus of our talk today. So what do we know about our unit? So we are part of the Clinical Information Network that some of you may know about, which is a system for routinely collecting data in various hospitals here in the country. And this data is collected from patient records with use of a REDCap system. And based on that, certain analysis can be done. So just soon after joining REDCap, we have information over the last 1 year. And these are patterns of babies at death in terms of their diagnosis. What were the percentages of their morbidities? So you can see the highest is actually in blue, which is a respiratory distress syndrome, followed by, more recently, especially this year, neonatal sepsis and meningitis. And previously was actually in the black, perinatal or birth asphyxia. So for us, definitely, it's a very common problem that actually leads to death. You can see the mortalities here for neonatal sepsis throughout the year throughout the last 1 year from April 2020 to now March 2021, range between around 20% to 30% of the mortalities. So it's quite a big issue. So in thinking about neonatal sepsis, we have to start with a definition. So it's considered to be a systemic inflammatory response syndrome that is secondary to an infection. And this infection is usually on the basis of a positive culture from what should be a sterile site. There is no consensus definition. This is commonly what is used to describe neonatal sepsis. It's categorized as early or late, and in some cases, late onset sepsis. So early onset sepsis are those babies who present at or before 72 hours of life. So from birth to about 72 hours of life. And late onset is considered for those babies who are more than 72 hours of life. You find some descriptions talking about early onset being more than 7 days versus late onset being more than early onset being less than 7 days and late onset being more than 7 days. For late onset sepsis, these are the babies who are presenting beyond, so late onset ranges between 72 hours to about 28 days of life, but there are neonates who will be with us in the unit, especially if they're preterm, and even beyond the 28th day of life mark. These babies, if they present with sepsis from 30 days to about 90 days, we consider that late onset sepsis. So looking at early onset sepsis, this is predominantly from vertical transmission of bacterial flora that is colonizing the maternal anogenital tract. Most commonly, you'll find the organisms that are described to cause early onset sepsis are GBS, or group B streptococcus, also known as Strep galactiae, and gram-negative enteric bacilli. So these are the organisms that will be found in that GI and also genital tract. So predominantly like Klebsiella or E. coli. Others that may also cause early onset sepsis are like Listeria, Enterococcus, Enterobacter, Staph aureus, and also rarely Coagulus negative staph. We're not really going to focus in this talk about non-bacterial causes of sepsis, but that's something important to consider because not all causes of sepsis are bacterial. So some babies may actually have sepsis from like herpes simplex virus or enterovirus, where they present very ill with fulminant disease and they tend to deteriorate very rapidly, and also candida, which is common, especially in extremely low birth weight babies. So in terms of early onset sepsis, the risk factors we'll consider, especially looking at maternal history. So is there history of GBS colonization? Was there intrapartum fever? And what is commonly described is more than or equal to 38 degrees. Was there premature rupture of membranes? And here the important cutoff period is 18 hours. However, what has been shown is rupture for even up to 24 hours. The rupture is directly proportional to the duration of time of the exposure of the infant to that rupture. So the longer the mother is ruptured, the higher the incidence of sepsis. So it's important not only to say that the rupture has been more than 18 hours, but it's useful information to say how long, because that again increases the incidence of sepsis. And whether there is any evidence of chorioamnionitis that is suspected or confirmed. And remember, suspected chorioamnionitis is a mother presenting with fever, more than 38 degrees, as I talked about, with fetal tachycardia. And that's described if you have a baseline CTG, a heart rate of more than 160 for more than 10 minutes, or maternal white cell counts that are raised above 15,000, or purulent fluid from the cervical os. If you have confirmed chorioamnionitis, you need to demonstrate infection. So you'll have any of the features I've described in suspected chorioamnionitis together with, for example, a positive gram stain from amniocentesis. So the amniotic fluid is positive on gram stain, or you actually culture a particular bag on the amniotic fluid, or placental pathology is actually positive or suggestive of infection. So any of those, you need to consider infection, a potential risk of infection in the infant. In terms of infant risk factors, commonly what has been described is prematurity, and the more premature you are, the higher the risk of sepsis and low birth weight. So this issue of GBS, is this really an issue in our setting? There's quite a bit of work that has been done in this area all the way from 2019 by Salat et al. And his population, he looked at mothers who were actually in KNH attending clinic here, and they were between 35 to 37 weeks, and found a GBS prevalence of 25%. More recently, Gisouvet et al. Has found that for mothers who are between 12 to 40 weeks, so he had a wider cutoff range in terms of gestation, the GBS prevalence was quite similar to 20%. And note that what is quoted in developed countries is anywhere between 10 to 33%. So this would be actually considered high prevalence for for GBS. And these are both from vaginal and also from genital, from anorectal swabs. And these are both swabs and culture for GBS prevalence. So the concerning thing from this is that you note the high prevalence of resistance for most of those serotypes of group B strep. So he noted resistance of about 72% for PENG, ampicillin resistance was found at about 55%, clindamycin at 30%, and vancomycin at 24%. And these are the most commonly prescribed antibiotics for intrapartum prophylaxis. So this is something probably we need to start thinking about. Do we need to start screening our mothers? And you know, what do we also need to be doing antimicrobial susceptibility testing to kind of decide what antibiotics we can select? As we think of doing that, we need to ask ourselves, do all babies exposed to GBS eventually develop early onset GBS disease? And here we know that without prophylaxis, as what is currently happening in our setting, so without intrapartum prophylaxis, half of the babies will actually acquire GBS from the mother. But of those babies, only 1 to 2%, so only 2 in 100 will develop early onset GBS disease. So if you look at large populations, this is quite a large number, and GBS disease has been described to be very severe, very progressive, and probably the reason we don't see it as much is maybe most of these babies actually die before presenting for care. So these are the babies who actually need very aggressive support from right at the beginning. Note that late onset GBS disease is not impacted by intrapartum prophylaxis, as these babies have been exposed to the bug in their environment, so at home with their caregivers or in the community. Okay, so in talking about late onset sepsis, this is from colonization with pathogenic bacteria in the infant's environment. This may be either in the home or in the hospital. Remember, we said these babies are more than 72 hours old. The common organisms described are, coagulase negative staph, so Staph epidermidis, Staph hemolyticus, Staph aureus, Candida, E. coli, and as well GBS, because you can have late onset GBS sepsis. Others are, for example, Enterobacter, Klebsiella, very common in our setting, Pseudomonas, Serratia, and Citrobacter. So the risk factors will be prematurity. These babies stay for long periods in our neonatal units. The babies will have several invasive procedures. They will have central catheters, urinary catheters, endotracheal tubes, which interrupt the mucosal barriers and predispose them to exposure to these bugs in the hospital environment. Also, the use of histamine receptor 2 blockers and proton pump inhibitors has been shown to change the microbiome in the intestinal gut of these infants and predispose them to sepsis, along with delayed feeding and not using maternal or mother's milk. So now we change gear a little bit and just move to discussing presentation. So the presentation of sepsis, as you know, is quite non-specific. So I just pulled this slide from one of our common pediatrics textbooks. You can see that it can be actually multisystemic. So generally, you'll have this comment from the nurse or the caregiver that the baby just doesn't look right, or they're not doing well. They may have some temperature instability. So preterms tend to present with hypothermia. Term babies tend to present with hyperthermia or fever. And they will have poor feeding, may have edema. In terms of the GI symptoms, you'll have distension, vomiting, diarrhea. They may have some organomegaly like hepatomegaly. Respiratory system, they may present with apnea, which is quite common in preterm neonates. They may be tachypnic, especially if they are term. Have indrawing, flaring, signs of respiratory distress, and of course hypoxia with cyanosis. You may find that they're not passing urine well. You look at this, their skin, they look mottled, they are clammy, the skin is cold, they may actually be tachycardic or bradycardic. And actually, as a late sign, they may actually have gone into shock and be hypotensive. In the CNS, you may have signs like irritability. They're not there, you can't quite soothe them. They are irritable, lethargic. They may have seizures and abnormal neonatal reflexes. You feel the anterior fontanelle, it may feel full, and they may have this abnormal high-pitched cry. And you may have other symptoms in the hematological system like jaundice, petechiae, purpura, or even overt bleeding if they have progressed all the way to DIC, which tends to be very common in gram-negative sepsis. So with those non-specific signs, there's been a lot of work to try and identify which are the most critical to identify babies who have a high risk of death or who have severe sepsis. So this is from the Young Infants Clinical Science Study Group, and they looked at low-income countries. So the study was done in Bangladesh, Bolivia, India, Pakistan, and 2 sites in Africa. So that was in Ghana and South Africa. And for children who are less than 7 days, so 0 to 6 days, they had a population of just over 3,100 infants. And they also looked at infants who were between 7 to 59 days, about 5,700 of them. From a list of about 31 signs and symptoms, they were able to narrow down to these 12 signs that are listed here, which were found to have a very high predictive value for severe illness, especially in the first week. So you can see history of difficulty feeding, movement only when stimulated, lethargy, abnormal temperature, so either hypothermia or fever, prolonged capillary refill time, and then tachypnea with a respite rate of more than 60, granting cyanosis, severe injury, history of convulsion and stiff limbs. When they reduced these signs to about 7, based on the prevalence of those signs, they found that there was not much change in the sensitivity and the specificity. Those 2 were preserved. And based on that, this is what we use in our current comprehensive newborn care protocols. So the baby who presents with signs of severe neonatal sepsis, you'll find that either they are unconscious or there's a history of convulsions. They're unable to feed at all. They may have apnea, cyanosis, bulging fontanelle, and persistent vomiting. For the baby who presents with just movement only when stimulated, you observe their feeding and they're not feeding well, abnormal temperature and severe chest or injury. They don't have severe neonatal sepsis, but they have some evidence of neonatal sepsis. So based on that, previously we've been using the basic pediatric protocols. Currently, these comprehensive newborn protocols are actually under validation and review by the ministry. So we should be seeing them more in circulation soon. You will find that if the baby fulfills any of those listed in the top box here, then your care plan should include admitting this baby as a critical infant, when they need critical monitoring and interventions. You need to actually do a blood culture and a lumbar puncture. Start them on crystalline penicillin and gentamicin, and we'll talk a bit about our antimicrobial susceptibilities in subsequent slides. You also need to give some kind of supportive care. So consider feeding via NGT or IV fluids. Make sure you maintain a normal thermoneutral environment by keeping them warm and exposing them if they have a fever. Give them oxygen if required, and prevent and manage hypoglycemia. If they don't have any of these signs, but they have those signs that suggest they may have sepsis, then this baby will fall under category B. These babies, you start them on crystalline and penicillin. Penicillin and gentamicin for 48 hours, and consider switching them to oral amoxicillin for 5 days to complete a full 7-day course if they have shown signs of improvement. Again, you need to give them supportive care of feeding, keeping them warm, and managing and preventing hypoglycemia. If none of those are present, they may still have signs of other illnesses like omphalitis, they may have jaundice. So they will still need some degree of assessment. So now, what investigations should you do for these babies who present with what you think is severe sepsis or neonatal sepsis? Commonly, we ask for a white blood cell count or a complete blood count. What has been shown to be most predictive of a positive culture or positive infection is low cell count. So you have a low white blood cell count of less than 5 times 10 to the power of 9, or low absolute neutrophil counts. So this, you can see, is much less than what would come, looks like a moderate to severe neutropenia of less than 1.5, and an increased IT ratio. So that's the immature to total neutrophil ratio of more than 0.2%. And this can be obtained by just getting a peripheral blood film reported by colleagues in hematology. This was more predictive of early onset sepsis than actually a high total white cell count. So if you have a baby with a high white cell count, you may also consider sepsis, actually, if they have a cell count of more than 30 times 10 to the power of 9 per liter. So those extreme in the cell counts are what you really need to be thinking about. For late onset sepsis, we usually consider also thrombocytopenia of less than 50 times 10 to the power of 9. We also have very high white cell counts for late onset sepsis, of cell counts of more than 30 to 50 times 10 to the power of 9 per liter as a predictor for sepsis. IT ratios may also be useful if you're considering late onset sepsis, so be sure to ask for them. We'll talk about CRP in the following slides, so I'll skip that for now. Regarding blood culture, remember you need to collect an adequate sample. So even in neonates, we try to collect a minimum of 1 ml and do proper skin antisepsis before you collect the sample. So you either collect from a newly punctured vein or a newly inserted central catheter, or even from an arterial line, or that has just been inserted, or from an artery. Lumbar puncture is also something we're going to talk about in the subsequent slides, but something you need to consider, especially for late onset sepsis or early onset that presents with signs of meningitis. Urinary cultures, we tend to have a very low predictive value for positive cultures for babies who have early onset sepsis. This is commonly an issue for late onset sepsis. So that baby who is more than 3 days old, you need to be considering, and especially more than a week old, you need to be considering doing urine culture as part of your septic workup. Other cultures will be guided by the focus that you suspect. So tracheal cultures, for example, will be if you are suspecting like a ventilator-associated pneumonia. This is quite helpful, especially with signs that there's been increased ventilatory requirements. Joint aspirates, if you're suspecting like a septic arthritis, which tends to be quite common in neonates, especially preterms who have had a long hospital stay. And then imaging is also guided by, depending on the system that you suspect is affected. So for example, if you're thinking neonatal pneumonia, you will have to ask for chest x-ray. Meningitis, you may ask initially for a cranial ultrasound, but MRI will be the most useful there. And then of course your x-rays for those particular joints with ultrasound guided aspirates as needed. Okay, so regarding inflammatory markers, so we're seeing these becoming much more available than previously. We commonly ask for CRP, which is also known as the C-reactive protein. It's induced by pro-inflammatory cytokines in the liver. Note that it rises a little bit later, so between 6 to 18 hours, and would peak anywhere between 8 to 60 hours after exposure to a particular stimulus. There's increased sensitivity with serial measurements, so you want to get repeated CRPs to kind of guide you as to whether your impression of sepsis is correct or not. And note that there's a very high negative predictive value for early onset sepsis with repeated normal CRPs. So if you get several normal CRPs, it's unlikely to be sepsis. You need to be cautious in meconium aspiration syndrome, intraventricular hemorrhage and perinatal asphyxia, because these conditions have inherently elevated CRP. So interpretation would be difficult. Regarding procalcitonin, and we keep getting asked, should we ask for procalcitonin? Note that it's produced by the monocytes and hepatocytes. Levels rise much earlier than CRP, so between 4 to 6 hours, and plateau about 8 to 24 hours post the stimulus. The challenge is that there's actually a physiological rise in healthy newborns that peaks at about 24 hours and then plateaus at somewhere about 48 hours and slowly deteriorates to normal values at about 72 hours. So most studies are actually conflicting in terms of the utility of procalcitonin, so it has as yet not been well validated for use in newborns. So when should we perform a lumbar puncture? I apologize, the slide may be a bit small, but I'll try to focus you on the areas I really want you to take away, and you can always go to the reference to review this in more detail. So lumbar puncture is something we need to actually consider doing more of, especially for those babies who are presenting with what we think is late onset sepsis. You need to make sure that there are no contraindications for lumbar puncture. So there's no coagulopathy, no increased intracranial pressure, infection at the site, and the baby is not clinically unstable. If consider a lumbar puncture strongly if they were already exposed to antibiotics, but they have a clinical deterioration, or they don't actually improve by the 72-hour mark, you need to consider reevaluation with a lumbar puncture as well. If they present actually, in that period where we consider late onset sepsis, part of your workup has to include a lumbar puncture, unless they have specific signs that, this looks like for sure a neonatal pneumonia, for example. If they present with early onset sepsis, you consider a lumbar puncture if you get a positive blood culture, regardless of their clinical status, because you need to decide how long to treat for. For bacteremia with a negative culture, we commonly treat for anywhere between 7 to 10 days. But for a positive CSF culture, you may need to treat for between 14 to 21 days, depending on the organism that's isolated. And then if the baby actually presents with symptoms of meningitis, then you'll go ahead and actually do the lumbar puncture. If the clinical instability has resolved, you still need to consider doing a lumbar puncture in those indications I spoke about, because even though you may not get a positive, organism identification, you may have other signs that may be useful to guide your therapy. For example, you may have still elevated white cell counts, elevated protein that is in keeping with a meningitis that may actually guide you to prolong your therapy. So now, what do we know about our local antimicrobial susceptibility pattern? So there's some work that was done by Dr. Masika and colleagues back in 2016. And as I know, we don't have an update of this report, but it was quite robust and informative in terms of thinking about what are our susceptibilities for sepsis. So I'm going to talk mainly about newborn unit for obvious reasons. And when you look at, they were able, over the 3 years between 2013 to 2016, the blood cultures done in the hospital from the newborn unit were about 591. Of those 591 cultures, we had about 128, the vast majority being positive for Klebsiella pneumonia. That was followed closely by Staphylococcus epidermidis, which we also know as coagulase negative staph or CONS. And then third on the list was Staph hemolyticus, which is also another organism commonly classified as CONS. And also Pantoia species, which was actually third, and Staph hemolyticus was fourth. We have others that are listed here. I'll not belabor them, but a mention of Staph aureus at about 24 positive isolates, and then E. coli at 20. GBS, not as common as we thought. You can see Strep agalactiae was only in about 6 isolates out of the 591. So what was the sensitivity of those common bugs, for example, Klebsiella? So you can see sensitivity to gentamicin, first-line aminoglycoside was below 30%, much more sensitive to amikacin. And this is the pattern we still see currently over 5 years later. In terms of cons, the sensitivity was about 67% to gentamicin. Looking at susceptibility to penicillins, obviously there's usually an inherent resistance to ampicillin, so it was very low for Klebsiella pneumonia in terms of sensitivity, and also very low PENG, common crystalline penicillin, sensitivity for cons. Now looking at the beta-lactams that we have available at times, like piperacillin, tazobactam, Klebsiella showed about 30% sensitivity to that. And a drug we commonly don't actually use, ampicillin and sulbactam, had quite a good sensitivity for the cons. How about Cephalosporins, which we kind of tend to prescribe almost like a knee-jerk reaction as our second line? So if you look at Klebsiella, the sensitivity to cefotaxime, ceftazidime, and ceftriaxone was very poor. When you look at Staphylococcus epidermidis, basically the cons, sensitivity actually was much better when you look at, for example, cefuroxime. It was at about 66%. Obviously, the drugs of choice in this instance would be, for example, meropenem with a much higher sensitivity at about 71%, and then vancomycin for our cons with high sensitivities at about 97% for both. So what conclusions can we draw from this report? We need to actually have that blood culture and susceptibilities to drive our antibiotic choices, because assuming that the bugs that we have are susceptible to the organisms, as you've seen in the report, is not always true. So we need to actually do the culture so that we can actually confirm that the bugs are susceptible. Frequent antimicrobial susceptibility reports are actually helpful because this can guide our empiric therapy, because clearly you can see the choice of ceftazidime and amikacin is something maybe we need to be rethinking as our second line choice of antibiotics. And also the rational use of antibiotics. You need to select based on your organism and its susceptibility. So when should we actually stop IV antibiotics? So there was a study done by one of the residents back in 2018. I think this was published in 2019, Pretty. And she found that when the condition of the baby, looking at the condition of the baby, despite improvement at about 48 hours, so about 50% of the audit she had done, 50% to about 65% of babies had improved in the interval between 48 to 72 hours, the clinicians elected to overwhelmingly still continue the antibiotics rather than considering a switch to oral antibiotics. So that would probably be more helpful because you will reduce the length of hospital stay for these babies and exposure actually to our late onset bugs. So something we need to be thinking about more. In terms of the CRP utilization and blood cultures, quite poor, especially 2017 to 2018. These numbers have probably evolved now because we now ask for cultures and CRP routinely. So I just wanted to remind you this slide and the issue of actually switching for those babies who have actually shown clinical improvement to oral amoxicillin, which can be actually given at home with a plan for follow-up care so that you reduce the length of hospital stay for these babies who have shown clinical improvement. So I think that's the end of my slide. I'll welcome any questions or comments, and thank you very much for your attention. Hello? Hello?
Hi, Doc. Yes, we can hear you.
Oh, okay. Sorry, I thought I was alone now. Okay.
Dr. Kalima to get back on.
Okay.
Yes, but we do have a Q&A section.
Okay.
Some of our participants have posted a couple of questions with regards to your presentation.
Okay.
Are you able to navigate to the Q&A?
Let me see. Yeah, I can see them here. So
Yes.
let me see here. So JCV speaker asked, what is the first line of treatment? I think this one we've gone through. It still remains crystalline penicillin and gentamicin, right? Unless you're suspecting that you have meningitis, then you will need to consider what are the common bugs the baby may be exposed to. And you actually still would start with crystalline penicillin and gentamicin, especially if it's early onset. Based on the cultures you get, then you will narrow your spectrum. Okay. Priska Ongombe asked, good afternoon. If a baby is born with a blood group O positive mother, but babies, I think I'll defer this question because this is about blood group incompatibility and just focus on the ones on sepsis for now. Sirma asked about the meaning of GBS, which is just group B streptococcus or Strep galactiae. Bill Kigathi asked, what's my take or our take on ceftazidime monotherapy in neonates with sepsis and concurrent suspected or confirmed acute kidney injury. So if you're thinking it's early onset sepsis, remember ceftazidime doesn't have a great gram-positive cover, so you need to consider adding ampicillin or PENG or crystalline penicillin for us, along with the ceftazidime, just to expand your cover. Because remember, these babies, you need to actually avoid glycosides because of the AKI. There's an anonymous attendee who asks, in pediatrics, we aim at pain-free management. If you suspect meningitis, you treat it, no need of doing an LP. So this is actually incorrect practice, because you cannot treat meningitis blindly. It has very severe sequelae, and not just regarding neurodevelopment, but hearing, vision. You could also get a post-meningitic hydrocephalus. You could even complicate with getting pus collections in the brain. So you need to adequately treat meningitis. Partially treated meningitis is a very difficult condition to address. The only way you can adequately treat meningitis is if you look for it, and the definitive investigation is actually a lumbar puncture, as I discussed in the indications on the slide. So the issue of pain-free does not apply because you can actually give analgesia for a lumbar puncture. I hope that's helpful. Okay, there's a question here about Galaxy Wilberforce asked, is there any worry for early full or partial Fontanel closure? I think I'll skip this one just to focus on neonatal sepsis. The role of procalcitonin, I think we've talked about that on the slides. Thank you, Georges. Thank you, Lyndon. Okay. There's an anonymous attendee comments that worrisome antimicrobial susceptibility patterns. Which antibiotics do we now use empirically for neonatal sepsis? We still actually use, especially for early onset, crystalline penicillin and gentamicin. But this is actually guided by culture. So at the point of admission where you're drawing your samples, you include a blood culture before your antibiotics. And if those suggest that you need to change your spectrum, then you change based on those. So really the focus of the take home is the need to actually do your blood cultures to guide therapy. The next question was about, I don't know if I skipped one, but there was a question about what in the case of a negative culture. So in the case of a negative culture, then basically you ask yourself, was it appropriately drawn? Was it an adequate sample? Has there been clinical resolution of the symptoms? Are my inflammatory markers negative? If all those are present, then it's unlikely to be, you probably do not need to continue with your antibiotics. Priscilla asked, oh, thank you, Priscilla. Okay, I think this is is it a comment or a question? When we have doctors and specialists coming from abroad, what measures have been put in place to update them on Kenya's protocols and microbial susceptibility values? So the thing is that most Kenyan pediatric and neonatal protocols are widely available online. So this is something you can actually share with colleagues who are planning to come for electives and so on, experience. I mean, they're widely available, are things you can share with them. A question about the concept of de-escalation of antibiotics. I think we've kind of answered this, and the need to actually be guided by your cultures. The role of flagyl. So we use metronidazole if we're thinking there is anaerobes as well in the, as part of the infection, especially for babies who are presenting with necrotizing enterocolitis, has features that it's actually stage 2 or confirmed based on X-ray findings. They're probably about to perforate. So these babies, because the GI tract tends to be colonized with anaerobes, you need to extend your spectrum by adding anaerobic cover. Felicitas asked about, is microbiology lab able to do candida or fungal cultures? Yes. Do you recommend routinely use of antifungal in extreme preterms? So most guidelines talk about if you have a prevalence rate of more than 10% for candida, you should actually be routinely giving prophylaxis to extreme preterms. And remember, the prophylaxis is long. It's a duration of about 6 weeks. Or if you have a central line in place, you have to give it up until you take off your central line. Something to definitely think about. We don't know about our prevalence because in what I presented, it was mainly on bacteria. We didn't actually, they didn't actually report fungal infections, but this is something we definitely should be thinking about. Okay, the next one is, do we have data and trends? Maybe you can clarify. I'm not sure whether you mean on sepsis. Okay, this looks like a complex case. You can sidebar me for that. Is there any correlation between the use of antenatal corticosteroids and neonatal sepsis? I mean, this is an interesting question because there was a study done, I'm trying to remember, I think back in 2014, that had shown mothers who received antenatal corticosteroids had a higher incidence of neonatal sepsis. And actually one of the sites was Kenya. The only rider to this study was that we did not actually correctly, report gestational ages because gestational ages are not routinely taken. We don't do first trimester scans to confirm mom's EDDs, expected dates of delivery. So most of these mothers who received antenatal corticosteroids were not within the recommended gestation, so not between 24 and 34 weeks. That was one of the reasons why it was thought these older babies with larger birth weights actually ended up having some of the concerns, like, for example, suppression of immunity and neonatal sepsis reported. But an interesting question. Okay. I thank you, Kimani. Priska asks, do we have information on the sensitivity to amoxicillin? I don't think we have this as yet, because as you know, we don't routinely switch to orals, but this is something we need to start doing more and develop and get more data on. And what have we observed that the lab, we have observed that the lab does not perform sensitivity for positive cultures for cons. Yeah, this is actually has been an issue that we've been in discussion with the lab for. For us, we actually consider cons a late onset bug. Of course, you have to collect, it's mainly considered a contaminant, but you have to collect the sample well to rule out those issues of contamination. Most of the babies who are presenting and needing for you to do a blood culture are sick. So when that blood culture returns as cons, I would not disregard. I would actually take it quite seriously, especially if they have an invasive, maybe they are intubated, they've had a urinary catheter, they've had repeated attempts at cannulation. So something we definitely, you need to actually discuss with the lab to consider doing for you sensitivities. Okay. So a question about the management of neonatal septic shock. No change in the guideline, remains the same. So the approach is predominantly supportive with fluids, inotropic support, and actually a consideration of what are the particular hemodynamics. So it's not a question I think I can answer just in a statement, but we're happy to, to have another session on that. So the next one was from anonymous attendee who comments, many babies in KNH have sepsis and AKI. Commonly, we don't seem to do dose adjustment based on kidney function. Definitely something we need to consider. And not only dose adjustment, but actually doing drug therapeutic levels. As you know, aminoglycosides are supposed to be dosed based on their therapeutic levels. What is their trough and peak levels, and you adjust the dose based on that. So something we don't currently do, but we definitely need to consider in terms of actually optimizing our dosing for our patients in that regard. Thank you for that comment. Prolonged jaundice, I think I'll skip that. Maogo talks about, or gives a couple of comments. We clearly need to rethink our second line antibiotics. Yes, definitely. So why ceftazidime and not cefotaxime? So if you saw in the data, actually cefotaxime, and shockingly, you'd think cefotaxime is a good choice for a gram-negative late onset sepsis, but our antimicrobial patterns just show us about 13% of the isolates were sensitive, similar to ceftazidime, which was, I think, around 17%. So it doesn't seem to be overwhelmingly better. In fact, the take home is that our cephalosporins for late onset sepsis, probably something we need to rethink. And would flucloxacillin and amikacin be a better second line? This has been my thinking, especially the selection of amikacin. Fluclox for your Staph aureus, your enterococcus. It may not be beneficial for coagulase negative staph because they tend to be more sensitive to vancomycin. But I think something we need to think more about. Choice of antibiotics for neck. We don't have actual local data on this, but probably considering adding that metronidazole escalating to your next line of antibiotics as the first thing, and also adding metronidazole as well. David Gunjiri asks to repeat. I think I'll take just the last few. Okay. David Gunjiri asks, repeat the total blood count findings. I think you mean in terms of what is suggestive of infection. So low cell count, so less than 5 times 10 to the power of 9. You need to be considering this is a high risk of infection, or very high cell counts more than 30 times 10 to the power of 9. And for the absolute neutrophil count, so severe neutropenia, so absolute counts of less than 1.5. And also if you're able to get immature to total neutrophil ratios from a peripheral blood film, that's also helpful if it's more than 20%. Okay. Dr. Ndavi asks about what is the level of current evidence for use what is the current level of evidence for use clinical features investigation? Maybe you can rephrase the question. I'm not getting it very well. Prophylactic antibiotics in prolonged rupture of membranes. I think I'll defer this to my obstetrics colleagues who can tell us about the MASA protocol and so on. What is the recommended treatment for viral sepsis? Hello?
Hello, Wairimu.
Yes.
This is Ndavi.
Yes, Dr. Ndavi.
When is this?
Yes.
The question I was posting is, what is the level of evidence for use of clinical features?
Yes.
In the diagnosis of neonatal sepsis, the level when we combine the clinical features and the investigate the imaging in the diagnosis of neonatal sepsis and use of all those armamentarium you have just taken us through in the investigation in the diagnosis of neonatal sepsis. So
yes.
When we use any of these, we know the level is level 1 or level 2 or level 3, depending on the methodologies that give rise to that evidence.
Yes. So unfortunately, we don't have a specific local study. What we have is more Western literature that quotes that, and most of that literature talks about neonatal sepsis calculators that look at what you have described, risk factors, clinical presentation, and then adding together your laboratory findings. Of course, putting the three together, you have the highest predictive value in terms of diagnosing sepsis, which is why we never say that you use only one parameter. For example, a positive CRP in a normal, well-appearing baby, that has the lowest predictive value for sepsis. So the idea is because this is a very non-specifically presenting disease, to widen your net and actually expand the resources you have available. Look at the risk factors you have, the ones we mentioned. Look at your lab parameters, and also what is the actual clinical presentation of the patient. So highest prediction with all three put together. I hope that's helpful. Mm-hmm. I think that's it. Any other questions I may not have addressed?
I think you've covered most of them.
Yeah, I think for the ones that are remaining, they can be answered at a later date.
Okay.
Yeah. So I just want to thank Dr. Wairimu once again for agreeing to do this lecture. It was a very interesting and informative lecture, and has generated a lot of comments and questions. Yeah, and we appreciate. I think we'll end the session here.
Okay. Thank you very much. And thanks for the questions and attendance.
Thank you, Dr. for your presentation as well, and also answering the questions.